All right. Hi, everybody. Thanks for joining. This is the October 2023 Wilderness Medicine Journal Club session through the Virginia Tech Carilion Fellowship Program. Today, we're talking about exercise-associated hyponatremia as well as endurance race medical support. Got a bit of a team with us today, so we'll be joined, and the session itself will be moderated by one of our fellows, Janelle Matthews. And we have a couple special guests. Our speaker includes Avi Patil from Stanford, also medical director with Racing the Planet. And we have Dave Young from University of Colorado, involved with our fellowship program and the WMS, as is Avi. And we have our article presenter, Alexander Vavra. So we have kind of a mix tonight. I'm going to do my best to sort of just stay in the background and introduce people. I think the little sandwich approach to this tonight will be best. So Alexander, you just message me if we ever need to move things along to make sure you get in and out. But Avi, can you get us started with your presentation you've got prepared?
Yeah, let me just sorry, I'm just trying to screen share.
And Andy, if you have anything you ever want to mention as well, I know you do a lot of medical direction out in the Western states as well. Feel free to join in.
Cool. Can you guys see my screen?
Yes.
Yeah. Cool. Well, yeah, thanks for having Dave and I here. Sorry I love cheesy titles on presentations, but yeah, I'm the medical director of Racing the Planet. So I've been working for them for about 12 years. And I'm just going to talk a little bit about what we do in preparation, kind of some of the common things that we see, and then hopefully lead into our discussion on the paper on EAH. So yes, we'll talk a little bit about preparation, some common injuries, and then go into a little more life-threatening things that we might see. Just some disclosures. So if you guys look at how many people are participating in running events, ultramarathons are just skyrocketing. The number of events there are every year are taking off. It's becoming a more and more popular sport. And I don't feel like it's no longer sort of for the extreme athlete, like everyday people are taking part in ultras these days. And with that comes along with people who are maybe a little unprepared and a little less trained. This is just the last 2004, 2014. You can see the number of races and events that have been climbing. And the demographic, it's definitely an older crowd. Most of our runners are probably in their 40s to 50s. The vast majority of them, and it's still a pretty male dominated sport, although we're seeing more and more females. And interestingly, we're just seeing discovering that in that distance of events, the playing field between male and female runners is sort of like getting smaller too. So we've had a lot of women runners come in like second place, third place. We haven't had a female win yet, but close. So some of the medical challenges that we face, this is real austere medicine. I mean, we are in the middle of nowhere in a different country that we don't know anything about. Some of our most challenging races have been in places where terrain is very extreme, like Nepal. I think Madagascar was probably our longest transport time to definitive care. We had a 3-hour car ride and a 4-hour plane ride to anything that was remotely a hospital. So we're really in the middle of nowhere. We have very limited communications. We have local phones. We still actually use Blackberries in some races because they work really well. iPhones, obviously, sat phones. We have satellite uplinks, but mostly we rely on two-way radios that are line of sight. We have very limited diagnostic tools. We've taken iStats and point of care testing to our races, but all those machines are really finicky. Not only do they require constant software updates, but the cartridges are really finicky. They need to be a certain temperature. And so we just find that it's really challenging to actually have blood tests. And our temperatures are really extreme, and all those cartridges have to be stored basically at room temperature. We've tried ice coolers, dry ice, and they're just really challenging to use. And then this is something that I sort of struggle with. I think that we all try to want to have a very wilderness experience, very feeling like we're in the middle of nowhere. And so I sort of struggle with all the things that I do and sort of balancing this idea of planning and safety and having a true wilderness experience. So on these races, what I try to do is sort of create the illusion that people are having a real wilderness experience, when really in the background, there's a lot of preparation and planning that has gone into it, but we don't really tell people that we've done all that. And so before we even go to the race, I do a lot of runner screening. So all our runners have to fill out a medical form. They have to have their physicians sign a form saying they're sort of fit to participate. And oftentimes I recognize the doctor's signatures that have cleared other runners because they're friends of mine. But we do a lot of screening in terms of, there's definitely certain things that I prefer not to have, like seizure disorders. Anticoagulation just sort of stresses me out a little bit. Seizures are the big one, because everything that we do out there decreases the seizure threshold. But really, I want to know in preparation, what do we have? Do we have someone who has anaphylaxis to a bee sting? Do we have someone who's a really bad asthmatic? And I reach out to them and communicate one-on-one to sort of come up with a plan on what's safest for them. We do a lot of runner education. So on our website, we have like papers that they can read that some of our physicians have written. And then we do a lot of runner education on site. We talk about nutrition and fluids. We talk about what are some concerning symptoms that they need to not only be aware for themselves, but symptoms that they should warn us about. Maybe that they observe somebody who's drinking more water than they should, someone who is vomiting. We sort of explain to them, we're not here they shouldn't be afraid of the doctors. We're not here to cut people out. What we want to know is what's going on and how can we help people succeed. We talk about hazards on the race. So different races have different hazards. We have races at altitude, we have races in cold and heat. We have races that have snakes and poisonous insects and things like that. And then we actually do a one-on-one nutrition check with every runner, going over calories and their electrolyte plans. And we have a 2,000 calorie a day minimum requirement. Definitely people are burning more than that, but that's sort of the minimum requirement that we've set for 7 days. And then we'll talk a little bit more about electrolytes later on. But we like to know that people they have some sort of plan on their electrolytes. Everyone is different. We'll talk a little bit more down the road on why everyone's so different. And everyone's requirements are different. Everyone's salt content in their sweat is different. And so as long as they have some sort of plan that they've been training with, that they can show us, we just want to make sure that they're doing that. And then I bring a team of doctors, and Dave has come with me on many races. But we bring a team of physicians. We try to have one physician for every 25 runners. And just because we're spread out all throughout the course, if we do end up taking somebody to the hospital, we take a doctor out because the physician will go with that runner to the hospital. And then we bring pretty much everything that we need. So we bring isotonic saline, hypertonic saline, all the antibiotics and medications that we think we might need, things for musculoskeletal injuries and splinting. And then, of course, we have like a resuscitation and code bag with a defibrillator. And so what I do for the company is I go to sites and sort of do planning on this on site. So I'll go to the local hospitals and figure out what all the resources are. And so I've done this at all of our regular races. And now what I do is I mostly work our roving races, which is our new location every year. And so I go a few days early, visit the hospitals. It's a lot easier. Those of you who worked in other countries know it's a lot easier to say no to someone you've never met than no to someone that you've met. And so I go to sort of grease some palms and make sure that if we bring a runner, we're going to get treatment. And as most of you probably know, in developing countries, you really need to have a credit card or cash on hand before getting services. And so this is my visit is more to sort of guarantee that we're going to pay for services rendered. And then, a lot of other countries this is the cardiac hospital, this is the neurosurgery hospital, they're all physically separated, this is the trauma hospital. And so trying to figure out what hospital we might visit with which different type of emergency. And then I work closely with our management team and our course team to figure out what is our evacuation plan. So from stage 3, checkpoint 2, are we going to drive forward? Are we going to drive backwards? Sort of like, what is our plan from every location on the course if we need to get to either back to camp, which we can handle most of our emergencies at camp, or if we need to go to a hospital, which is the best route to take. So if all goes well, most of our injuries are in the musculoskeletal world, right? We deal with blisters, maybe some sprains, some tendonitis, and then all the more serious things fall into like the medical category. Some dehydration, heat stroke, AKI, we get a lot of GI distress, unfortunately. We've had a few races where we've had some stray dog bites, and we have a race in Namibia that sometimes we worry a little bit about the jackals and the hyenas, but not too often. So we're going to spend a little bit of time just talking about some of these topics and then switch over to our article. Musculoskeletal injuries are pretty easy for us to deal with because really the question is, can you run or not? We're not going to like rehab ankles and knees and things like that. So people have a lot of, they're carrying a pack, they're pounding the pavement day after day. And so they get tendonitis, they get some effusions here and there. And so really the question is, can you run or not, or walk? And so we try to do a lot of taping, and we have a lot of certain patterns of injuries that we see a lot, IT band stuff, tendonitis, and so that's our main musculoskeletal problem. Tendonitis is, we'll talk a little bit about that real quick. The risk of rupture of a tendon when you have tendonitis goes up by nobody really knows the numbers. At least I can't find what percentage increase in tendon rupture you have, but we're not putting too much stress on these tendons that are inflamed. So it's not something that I worry about too much, but it is obviously painful. We see a lot of blisters. These are just some pictures of some of the bigger ones that we've seen. And these huge blisters are really a consequence of people not taking care of hot spots and sort of tending to their feet and taking blisters seriously. But it's probably our most race-ending injury. And this was a blister that we had in the Atacama. It was like, I think on day 2, this is a fellow who came along, one of our research fellows, who sort of put this blister all back together. And this was on day 2, and this person finished a race. And by day 5, it had sort of reepithelialized and healed, and this guy did really well. And so we try to sort of keep a biological dressing on this tender skin under the blister. But blisters, as you guys know, they're friction injuries. So it's just a lot of friction causes a local effusion. And we tend to pop them, try as sterile. I mean, none of it's as sterile, but as cleanly as possible, and tape them. And this is only to sort of prevent pain. At home, you'd probably never pop your blisters, but they're very painful. And we found that if we just pop them very small with a safety pin, drain it, and sort of tape it so that there's something else rubbing on that surface tape, we can sort of get people through the week. We do see a lot of subungual hematomas as well as blisters under your nail that are always satisfying to sort of drill a little hole with. We see a lot of GI complaints. Has anyone seen this picture before? This was from maybe like 10 years ago. And this reporter asked this guy if he'd ever, did he think about stopping and cleaning himself off? And his answer, this was just a half marathon. He said he really didn't want to lose time. And he finished in 21st place. It wasn't if he was winning, but we do see a lot of sort of upper sort of GI stuff, nausea. A lot of people get nausea, some vomiting, and just some general like reflux, probably because they're eating all this dehydrated food that they don't normally eat. But we see a lot of diarrhea too. Usually it will stop when people rest. They can have some diarrhea during the day or some urgency. And there's been some studies just on front country marathons that 84% of runners are occult blood positive. They probably got some med student to do that study. And then a lot of just intestinal cramping. And so no one really knows what causes all these sort of GI complaints, right? There's thoughts maybe some nausea is from some diaphragmatic irritation. Maybe it's eating meals and drinking water and then just having this like physical motion of jostling of all your intestines. There's some theories that say maybe it's friction of your peritoneum. There's, delayed gastric emptying, just putting a lot of complex carbs in your stomach when you're running. And of course, some infectious diarrhea. And then one thought is maybe there's this low level of mesenteric ischemia and endurance event. So you're spending more time than sort of is expected of your gut to have blood diverted away from it and going to your muscles. And so maybe all this diarrhea and sort of discomfort and occult blood positive is really from some really low level mesenteric ischemia. There's not been a study that I know that tests if fecal occult blood happens more often in ultras. Not something that I'm super interested in collecting data on, but I don't believe that study has ever been done. We do see some AKI. There's been a lot of studies in single stage races, and in single stage races, one study was just 4% in a single stage 160 kilometer race. We've seen in our races, mild AKI, even up to 50% sometimes. These are all pre-renal, we haven't had any sort of permanent kidney damage from our races. And, there's lots, most of this is dehydration and sort of pre-renal azotemia. But we really discourage people of taking NSAIDs during the race. Rhabdo, we haven't seen that much rhabdo, and most of our runners have trained pretty well. And so, but just another thought of a cause of AKI. I did have one runner, and Dave, I think you were on this race. He had one kidney from renal cell carcinoma, and his doctor I can't remember where he was from, like Vietnam but gave him steroids to take during the week to sort of decrease inflammation to help him get him through the week. And we were actually doing an ISTAT study on kidney function, and his creatinine came back from normal of 1 to 3.5. And so we sort of unblinded his data and pulled him out of the race. But he did recover, but it was from his doctor just gave him like 20 of prednisone to take every day.
First one. Yeah. Not a comment with you, Avi. Yeah.
Yeah. So we don't, cardiac arrests happen in one in about 100,000 in front country marathons. And most of these happen, I can't remember the term off the top of my head, but most of these happen right around the finish line. And there's this thought that like people get to the finish line, they have this like surge of adrenaline because everyone's like cheering them on, and they sort of have VFib arrest. And so most cardiac arrests in front country marathons happen towards the finish line. But people do see collapse sort of after the race ends. So they stop running, they get through the finish line, and they have a collapse. And this is called exercise-associated collapse. And so you get vasodilation while you're running. And then once you stop running, you stop getting the pumping action of muscles to help venous return. And so you get a postural drop in blood pressure. And so really the treatment is just give it some time and elevate your legs. And so this is often seen once people stop running versus a VFib arrest, which can happen once you stop running too, but more often happens during activity. We have seen some exertional heat stroke. The definition is temperature greater than 40 with CNS depression. And, heat stroke is super complicated inflammatory cascade pathway that leads to multi-organ tissue injury, rhabdo, liver failure, all sort, ultimately DIC. And the risk factors for exertional heat stroke are obviously strenuous exercise, high temperature and high humidity, so you can't really cool yourself down that well, associated with poor fitness, obesity, dehydration, medications like anticholinergics that decrease your sweating can lead to them, and then lack of acclimatization, which is sort of the biggest one that we fear. We put on races mostly in desert environments, and a lot of our runners come from cold climates, and so they're just not used to it. And full acclimatization takes about a week or two in that doing the activity that you're going to do in that temperature. And so, most of our runners and most people in general can't afford to come a week or two early to where you're participating in a race. And so what do you get with acclimatization? You get increase in your plasma volume, you get better blood flow to your skin to sort of facilitate heat exchange. You start sweating at a lower temperature, you increase the amount of sweat you have, but more importantly, you decrease the concentration of your of salt in your sweat. And so ultimately, all these things lead to you get a lower skin and core temperature for the exercise that you have acclimatized yourself to. And so what's the treatment for exertional heat stroke, right? We know that you get increased morbidity and mortality that is directly associated with the duration of how long your body is hot. And so really the treatment is just cooling them as soon as possible. And any thoughts on the best way to cool somebody? Really just cold water immersion, right? You can cool somebody really fast by just putting them in water. Is the best. And if you can't immerse somebody, then all the other things, wetting them down through evaporation, putting them in the shade, all those sort of things. But if you do have water, just getting them in water is the quickest way. Up to a point. I mean, we all hear about, well, you don't want them to start shivering, but really they're going to cool down if you put them in water. And so, we sort of balance with dehydration. We want to balance blood flow to your muscles and skin versus how much hydration you have. And we know that for every 1% decrease in body mass that runners get, this is all water loss, your skin temperature increases 0.4 degrees Fahrenheit. And so there's this balance of, well, we want to keep people hydrated, but not too hydrated because we don't want them to overheat. And so really, should we be telling people to drink to stay cool? I'm going to just talk. We can probably switch over, Justin, to kind of talking about the case or the paper a little bit.
Okay.
We can come back to some cases, but I just want to talk about just real quick.
Mhm.
I know when I was a kid and my coaches all told me, prevent dehydration, right? Like drink before you get thirsty. We were always like water was being pushed on us, and this was in 2002, or sorry, 2002, this is a while ago, an ad in Runner's World before the Boston Marathon. And I couldn't find the exact ad, but this is what they advertised. Drink early and often, 2 hours before the race, drink 16 to 20 ounces. That's a lot of water right before you drink or right before you run. And then drink 7 to 10 ounces every 10 to 20 minutes, which is a lot of water. And then don't wait to become thirsty, right? This is always what we were sort of taught. And then, we see all these ads, Gatorade, like drink, drink, drink. And all this data came from, all the studies on like VO2 max and fitness that shows a real decline in performance when you start to get dehydrated. So when you reach like 2 to 3%, excuse me, 2 to 3% dehydration, your VO2 max and all your sort of parameters of exercise performance start to drop. And so that started this whole push on drink, drink, drink. So yeah, so let's switch over to kind of the here, let me stop sharing.
If anybody has any questions about anything Avi just presented, hang on to it. Don't forget your question. We'll get to it once Alexander finishes his article, because Alexander needs to get out of here by 8, which is about a half hour away. So I just want to make sure we don't keep him too long. So don't forget your questions. And Alexander, take it away when you're ready.
All right, thank you. I'll work on sharing my screen here.
I can see it, but you're breaking up a bit.
Me better?
I think so.
Okay. to hyponatremia. 2018. We already got introduced, so we'll just kind of take it as it comes. The introduction introduces what is exercise-associated hyponatremia. It's the low blood sodium concentration, defined typically as under 135 millimoles. And this is without signs or symptoms. All right, the goal of this update is just to contribute to the overall understanding of EAH and just to provide the most recent research and in terms of how we can prevent it and care for it. All right, so some brief epidemiology where it talks about, typically it was thought to be ultra runners, Ironman triathletes, but they've actually shown that it can occur in other events, sporting events beyond just these ultra endurance races, although not as common. It shows like in high school football players or even just canoeing ultra distances. So it's just something that we need to keep on our radar as the epidemiology relates. After it kind of goes to the epidemiology, we get to the pathogenesis. Pathogenesis, the two main ones are split into over drinking, typically the overconsumption of hypotonic fluids. And this is what was just alluded to with kind of this marketing of, make sure you don't get dehydrated, make sure you keep drinking. That's where that comes into, because as we consume these fluids, our sodium concentration is related to the amount of fluid we have and sodium in our body. So if we're intaking more fluid, that means we're going to be have more fluids inside of us, which then decreases the amount of concentration of the sodium in our bodies. And the way they kind of measured this is through not only through sodium concentration levels, but that you can do it by weight gain. So you can kind of see that as you're consuming fluids, if you're consuming more than you're losing, you have a tendency to keep the weight on, which then causes you to become hyponatremic. All right, the other major consideration is this non-osmotic AVP secretion. So arginine or vasopressin AVP regulates our water excretion. And so it does this by through the posterior hypothalamus. And what happens is they believe there's like a non-osmotic stimulation. So they think that some athletes don't suppress AVP, and when they become hypoosmolality. And then another potential stimuli for the AVP, they believe it can be like non-specific stress, exposure to heat, medication, and even interleukin 6 that they get to. And with the interleukin 6, they believe it's kind of like a cyclic cycle, potentially, where you have you have the breakdown of muscle, and then that breakdown of muscle kind of enhances the secretion of AVP. This is more of a theory, but they definitely believe that this plays a role as well. So other factors are the sweat sodium loss, which was also talked about, how people sweat at different rates. And so this was a little difficult to measure unless you're measuring everybody's sweat rates. And but this is if you're sweating a lot in these hot environments, then it would be more of a cause for potential volume depletion. but given the variable sweat rates of athletes, it makes it more difficult to assess. They also talk about like non-osmotic active stores through like the breakdown of bone. They also talk about like the glycogen breakdown, which requires H2O to be released, and therefore it would need to be excreted if it can also contribute to these factors. That's what they're talking about. I would basically even go at like 3 kilograms of associated metabolic water it is caused for the kilogram of glycogen. In addition, we have like fluid absorption that they said, like towards the end of a race, you know, at the end, if you have rapid reabsorption of fluid due to the blood being elsewhere in our body, this is similar to the post-exercise collapse. They believe that what happens is now the blood rushes, you know, back, and so now your digestive system, which wasn't receiving a lot of the blood, can now start absorbing more, and then that rapid absorption of fluid would drop your sodium because now you have more fluid in your body. Right here, where the newer concepts of the bidirectional thing I was kind of alluding to with interleukin-6 playing a role, both because rhabdomyolysis causes interleukin-6, so the muscle breakdown, which then contributes to EAH as well. So they may be influencing each other. Now, how do we treat EAH? It's, you know, it depends on the symptoms. You know, if they're able to have oral intake, we can do oral options. You could restrict hypotonic fluid. You can give like hypertonic broth, salty snacks afterwards are another option. But this is if they're able to take fluid. So that in addition, if they're not having any vomiting, or if their sodium's not less than 125. If their sodium's like less than 125, or they have altered mental status, or they're vomiting a lot where they can't keep oral fluids down, well, then we would treat more so with hypertonic nasal saline boluses of 3%. And you would just fluctuate, just keep reassessing with that measure. So now we get to the prevention of EAH. So we've kind of talked about the pathophysiology, largely over drinking, mixture with some arginine release, non-osmotic stimulation. We talked about other causes such as the sweat rate, potential glycogen breakdown, food absorption at the end of the race. We talked about the treatment, you know, which would be either oral treatment options with hypertonic or fluid restriction, or the IV boluses. But ideally, you know, we prevent it from happening. So we don't have to treat. So for VAH, the best ways that we can do that, you know, is really education. And I think part of the Racing the Planet that they do so well, they talk about is the education of runners, because of the misconceptions of hydration. So we know that overhydration is the so, you know, they kind of give us a nice little guideline about how we should talk about educating people on hydration. And you know, it's big into drink according to thirst. So this typically goes against having scheduled times to drink. You know, I know I heard that, you know, once you are thirsty, too late, you're already dehydrated. In addition, it's, you know, how can we reduce, they talk about reducing availability of fluids along routes of exercise, weight during exercise. I think that one would be difficult to do. Maybe in a multi-stage race, you know, at the end of the race you can, but these long races, most runners don't want to stop. That would make it difficult. But like I said, the big thing is going to be talking about, like, how do we hydrate properly? The people are talking about sodium supplementation to try and assist in that regard. And you know, from this study, it's a little controversial because it doesn't really necessarily show the replacement during the race has benefited. What they have shown is that if you decrease your sodium intake the days leading up, typically those people are become hyponatremic. But the sodium during the race, and as much, at least from this, preventing hyponatremia. Okay. So kind of in summary, to go over the article, the two big factors in terms of what they think cause DAH: over drinking, so fluid. In addition, you have the theory of the arginine release and its non-osmotic stimulation playing a factor. You also have risk factors for EAH, which include a higher body mass, hotter environments, temperatures. And then also for treatment, it would largely be either restrictive fluid, hypertonic broth, if they can take orals, or if they can't and you're concerned, you do the 3% nasal saline IV boluses to assess. But one thing that's going to be very important is the prevention. So basically trying to drink based off thirst, not scheduling your drinks, and then just educate, making sure people know, you know, you can start the signs and symptoms. That would be good to look out for. Have any comments or questions before we can discuss some of this and get some of the experts' opinion on AC and how the role of sodium and some other stuff contribute?
So kind of overall, this was an article that was less, I suppose, methodic, like scientific, rigorous research. It was more like an overview and a summary, comprehensive but broad approach article. So it's mostly, I think we can dig into the discussion about the content of it rather than go into, like, there's not methods to review here. But anybody have any specific questions for Alexander? Otherwise, I'm gonna hand over to Janelle, our fellow, who's going to lead the discussion portion.
Awesome, Alexander. Thank you so much for that great overview of the article and EAH. That was awesome. I had a question for you, Avi and Dave. I loved hearing about the pre-race planning and kind of the discussion about you have with athletes one-on-one with nutrition and hydration and how that interplays with mitigating EAH. When kind of just from a logistical standpoint, do you have these kind of one-on-one meetings with times with athletes to kind of go over that and provide that education?
I can jump in only because Avi's had a chance to jump in and chat with y'all, just to be a new voice. Hi, everybody. My name is Dave Young. I have yet to be a medical director for RTP race, although it is happening this May, which is exciting. But I've been involved with a number of different races in the past, including now 7 RTP races, which has been wonderful. It's a great question, Janelle. There's always a pre-race meeting where all of the athletes will gather in a large room, and a number of different people will brief them on certain aspects of the race. Certainly the race director will talk about the course and about rules and things like that. And then the medical director, which Avi has done more than 20 times, will stand up will stand up in the room and give them a medical briefing for the course and the race itself, all related to anything medical. Certainly, like he mentioned in his talk, there's a number of different things that he would go through, but part of that would be talking about fluids, nutrition, warning about EAH, things like that. So usually it's not really a one-on-one discussion, but something where you kind of stand up and present to the audience of athletes. When we do gear check, the actual staff of the race will look at all of their gear individually, and then we as a medical team will also individually look at their food and electrolyte plan, and that happens after that racing brief, in the days right before, either the 1 or 2 days right before we depart to start the race. And so before we get out to the actual site, we typically would check all of their their electrolyte plan and foods. Jump in, Avi, if I missed anything.
Awesome. Thank you so much. That was super helpful. Right. I was curious, kind of the article mentions this bidirectional association with rhabdomyolysis. Is that something you've seen kind of in your experience?
There was I wrote down 3 different interesting parts of this article that I found noteworthy, and that was one of them, was the fact that rhabdomyolysis can cause the cyclical loop with EAH, which I have never really read before. Certainly, it's a really difficult thing to just witness. Again, Avi had noted that there's very little rhabdomyolysis that we actually see in these races. Again, most of these athletes are quite experienced and know their limits and know when to push and when to pull back. I feel like most of the rhabdo cases that I see maybe in the emergency department are people who are a bit more novice or are doing strength exercises. Certainly rhabdo can happen in people in an endurance event, but fortunately at least I haven't seen a ton. It sounds like Avi hasn't either. But I thought that portion of the article where it explained this like cyclical pathway where rhabdo can basically contribute to EAH, which then can worsen rhabdo and contribute EAH. So it kind of is this, feedback loop that worsens both diseases independently. Was something that I found super interesting and just hadn't read before. So that was something that I took from this article.
Yeah, we don't measure CKs, and we have never, just because there's not an iStat CK cartridge, but we've never had anyone get rhabdo. We've had people who we thought might have had rhabdo because they come in with like tea-colored urine, but you also can get this thing called foot strike hemolysis. So just from hitting the ground and pounding the pavement, you get hemolysis in the small capillaries of your feet, and so you pee what looks like rhabdo urine, this tea-colored urine, but it clears up right away. Just with some fluids. But yeah, we've never had anyone with rhabdo. And we've had people get measured for CKs when they go in the hospital. But the one thing I wanted to mention about the EAH2, like definitely just from volume alone, you can dilute your sodium down, right? We see this in the hospital all the time with people with like primary polydipsia or some kind of psychogenic polydipsia. But really in our runners, if that was the only reason, you'd have dilute urine, but our runners have really concentrated urine. So that vasopressin ADH is sort of like actively reabsorbing water in your kidneys. And so, this concept of weighing people, you should never gain weight in a marathon, in a race. And so there are some races that weigh people to watch for their weight. We have found that doesn't really help us in sort of determining who is susceptible or not. But what we have found is that, people stop urinating because they're holding on to water and they think they're dehydrated. And so they start drinking more and more water and they sort of go off this hydration plan they have. And that's when they get in trouble, is they sort of like, oh, I'm not peeing, but really it's because their body's not releasing water. And so people that we are suspicious of or get, worried about, we make them sit down and rest. And the half-life of ADH is pretty short. It's like 15, 20 minutes. And it's mostly renally cleared. And so as soon as we get these people to rest, they rest for 15, 20 minutes, they start peeing like crazy. Like their body just starts releasing free water. And we'll go just through a couple of cases later on. But really it's in this demographic, it's rarely hyponatremic. Sorry, hypovolemic hyponatremia. It's usually hypervolemic hyponatremia.
Thank you so much. That was a super interesting point about the having runners rest, and I hadn't heard that before. Thank you for sharing. I think we have a question here from Kira. And Kira's question, what are the key electrolytes you care about in a racer's plans, and how wide is the range of recommended intake between various athletes? Okay. Dave or Avi, if you wanted to jump on that question.
Sure. Really the key electrolytes that we do really care about is sodium chloride. Certainly there are a lot of other electrolytes that do matter, and electrolytes in our body, but it's usually all about the salt intake, just like we're talking about, right? We're talking about hyponatremia, and that's just one electrolyte, that's sodium. And so that is particularly the most dangerous thing that can happen, is when people go particularly low in their sodium, which we've kind of already talked about, and we will soon talk about with some cases from Avi. Certainly low magnesium or calcium is possible. And some of the supplements actually, like you'll see different electrolyte solutions that'll have different electrolytes in them. I don't think they matter quite nearly as much. So really what we're worried about is their sodium intake. And then how wide is the range of recommended intake between various athletes? It's so difficult. It's just too difficult to predict. The range is, potentially quite great, but we care less about what range to recommend to them, but really just to really let them know of the pitfalls that they can run into to avoid disease. So people who are, like we talked about before, and what the article highlighted, is people who are drinking a ton of free water, or drinking so much water that they aren't drinking to their own thirst, but just like following this guideline, like Avi had mentioned, where people are just having so much free water, like in that Boston Marathon, article or advert in 2002. Where it's just like this kind of absurd amount of water, and people, those are things that we always want to caution people about. That's the most dangerous thing. And then the other things that we had mentioned earlier to watch out for, and certainly what the article does mention in the number of different numbers there in the recommendations for prevention of EAH. So I don't know if you give any additional input, Avi. Certainly I like just to let them know basically what the pitfalls are, and to avoid those, rather than give them a specific amount for them to drink towards. Certainly if they had been like having a plan that they had trained with, is to stick to that plan, and that they've felt good and worked for them in the past. That is what I recommend. I don't recommend them doing anything different than their plan if in their race, just like you wouldn't want to wear brand new tennis shoes or running shoes.
Yeah, the recommendations, like from the sports, like whatever the sports medicine society is, it's crazy. It's like 30 milligrams to 300 milligrams an hour for endurance events greater than 3 hours of exertion. It's something really wide that isn't that helpful. There hasn't been really any study that I've seen to date that convinces me that you have to take electrolytes during when you run, especially in a stage race where, we all camp together every night and everyone eats salty meals. But intuitively it makes sense that you replace what you're losing, so we never tell people not to take them. But I don't know if anyone knows the answer to that. And because everyone's sweat content and insensible, all these losses are so variable, it's really a tailored recommendation.
If I can, I'd like to jump in with a couple comments. I have to leave at 5 o'clock, but I wanted to just kind of jump in with a couple comments. So I'm the medical director for the Western States 100. You guys did a great job with this presentation. Just everything you're recommending. I think everything you're talking about is really spot on with what we try to do at Western States. We've had a little bit different experience than you guys. We've had, so we do see a lot of rhabdo. Marty Hoffman, when he was the research director, published some articles showing that, mean CK concentrations anywhere from 20,000 to 32,000 at Western states. So we do see a lot of rhabdo. The fortunate thing is most of those runners don't have any permanent kidney damage. However, we just did publish an article. I actually did the article with Dr. Hugh Butler, who is the lead author on this study. She's come out to Western states, and we've had over a 3-year period of the race, we had 4 runners end up on dialysis after Western states. And so when we talk about this relationship, and interestingly, all of them were hyponatremic by the time they got to the ER. Now, we don't know if they were truly hyponatremic during the race, and we're kind of thinking about some research projects around that. But we're kind of wondering, did their hyponatremia cause their rhabdo to get worse, which then caused them to develop, renal failure to the point that they needed dialysis? The other theory is, well, maybe these people are getting pre-renal, they're not drinking enough, and that could be contributing to their acute kidney injury. So maybe we do need to have people drinking a little bit more. We don't have an answer on that, but that was something that Dr. Hugh Butler and I we've been kind of talking about for a while. Just a couple of other comments, and then I have a couple questions for you guys. I think the weights, we don't do them. The scales, like you guys, I mean, they're unreliable. If anything, we would be giving runners bad data, and they would start, they'd get on this, they'd be looking great, and we'd give them some data, and they'd like freak out, and we'd later find out that the scale was off. So we've kind of stopped. When we were weighing people, we did routinely see people would be 5 to 7% dehydrated and looking great. And so that was part of the reason, and part of that is that sort of pre-race hyper hydration that they get with the carbo loading. But it was really common to see that. One other comment, this whole topic is why I hate IV hydration spas. We tell all of our runners, avoid those things like the plague, both before and after the race. And I think as sports medicine docs, we need to be getting the word out. I guess my one question for you guys is in terms of, what are your thoughts, in terms of the heat stroke and hydration? Do you tell runners, if you're, worried about heat stroke, that you should be hydrating more? That's one of the things that we run into at Western states. It tends to be really hot, especially in the canyons near Auburn on Sunday morning. So a lot of the runners are like, well, I need to cool down, I need to hydrate more. But then we worry about this balance with hyponatremia. So I'd love to hear your thoughts on that.
We, almost all of our races are in deserts and very, very hot environments. And so we still tell people to drink as needed. It's hot all the time. And so we also we have found that all of our top runners, when we measure their sodiums, they're all hypernatremic because they're really just volume down and they've been going. And so the ones that are really exerting themselves in the front of the pack, we just don't worry about them as much. The ones who are in the middle of the pack to the end don't really care about their time. Like we just have very generous cutoff times. We don't have the sort of like the same pressures in the Western states of trying to finish under, 24 hours or whatever. So we make them stop and rest. Like if they're overheating, we just have them sit at our aid station and cool off. But we do, if we're expecting a particularly hotter day, we increase what we expect them to carry between each checkpoint. And so everyone has to have an extra 500 ml bladder that they don't have to carry unless we require it. And so we sort of keep track, we like ask people about how much they're peeing, like we sort of keep track of certain runners, and probably similar to you, we know who our problem children are going to be. And so we sort of keep track of those people in particular. And we communicate to the next checkpoint ahead, hey, check on so-and-so again. But we do, on particular hot days, encourage people to carry and drink probably no more than like a half a liter over a 10K.
Cool, thanks. And I think your point about having the runners, if they're not peeing, stopping to cool off is really, because that's the other thing, and you guys have probably seen this as well, as we have a lot of runners during the day, they're like, I haven't peed, and as soon as the sun sets and the temperatures drop, all of a sudden they're like, I'm peeing every 3 miles now because you get this diuresis as their bodies cool off. So yeah, interesting stuff. Thank you.
Yeah, thanks for your insight.
Andy, thank you for your insight you shared there. Let's see.
Yeah, I just had a quick question, if that's okay. Sydney, nice to meet you guys. Thanks for a great talk. I just wanted to kind of add on to the previous question about the pre-race assessment stuff. So you had mentioned this happens like a couple days before the race, but they're already kind of at site, they're already kind of in the host country type of thing. If you're not happy with what their plan is, like, do you have a way to like help troubleshoot them to be able to actually get the resources that they need to still participate? Have you ever actually had to like pull someone out of the race because they're just like totally not prepared and their plan is just not reasonable? Or like, how does logistically that actually work if you're not happy with someone's like pre-race assessment?
It's a great question. There's a number of different ways that we can help people. I think it all depends on whether or not they're receptive to the help. Certainly people are like, this is what I do. Look at my electrolyte plan, which is sometimes really nothing. And we refer them back to the rules where they actually need to carry some electrolytes to have the plan. And so usually if they have 0 electrolytes with them that they're going to bring, I refer them to the rules and then tell them they're going to need to bring some things. The tricky thing is, are they going to take them? Or are they just going to carry them along? And then if people are receptive, if they're like, oh, I haven't really thought about this, good point. There's usually enough either between the medical team will have a small supply of electrolytes that we're able to give them from our supply. And there's also typically a number of runners who carry way too much, and we like to pare them down and give them some advice of, I think you actually need to take a lot less. And so there's usually some leftover things where like, this person has a lot of excess. Why don't you ask them to see if they can get some from them? So it all depends on where they're at in if they're pre-contemplative or contemplative or ready to go. Just another point there is, for the people that we really think are either under nutritioned or under electrolyted, as before they start, we really as a medical team make note of that so that we're able to watch them as they go and really provide them feedback, right? If they have struggle out in the first day, or maybe the second day, they're really struggling, like we really keep a close eye on them and just provide counseling with them to be like, look, I really think the problem is your lack of electrolytes. Why don't we give you some chicken bouillon, which we bring with us as the, thing. Why don't we get you to try these 1 or 2 things? And then they usually kind of come around to get better. I have never pulled anybody from a race based on their inability or unwillingness to carry electrolytes.
And we're usually in a place that has like some stores where they can go buy some things. The tricky part for me is, we're a very international race. Usually we have like 35 to 50 countries represented. And I had a runner from Vietnam bring these little salted fish that were like this big, and that was his electrolytes. I'm like, I have no idea what this is. And he was like, this is what I do every race. I've done 20 ultras before, and he just sucks on these fish. I'm like, all right, I guess, like, good luck with that. And so it's kind of fun to see what all these different cultures bring. Like I've had Italian runners bring like vials of olive oil that they just drink for calories, and Parmesan cheese and prosciutto. It's but you do get a ton of your salt from food, and everyone eats a lot of food at night to sort of replete themselves. So
Awesome. Thank you.
Awesome question there, Sydney. I saw in the chat here, Andy, you shared some awesome information. A great article everyone can see in the chat here about rhabdo there, and then also Andy's case series on dialysis runners. So I'm definitely going to be taking a look at those later. Thank you for sharing those with all of us. And then I believe there are some case studies. Is that kind of the next direction here? Does anyone have any questions, any additional thoughts about the article?
What's our timing? How much time do we have? Because we can.
It's pretty open-ended. It's mostly as long as people are interested and still entertained and joining in.
Yeah.
Justin, I can take that question in the chat before we can turn it over to Avi to do the
Yeah,
case.
it's my own little personal.
Yeah, that's fair. Only Avi knows this very well, but Avi met me as a tiny, small second-year resident in the Atacama Desert, and the bane of my existence was to make these damn iStats work. We were doing a research project, studying a number of different things, but I needed to make these iStats work, and they were way too hot during the day, and they were way too cold at night. And so during the day, when we had to use them, we actually had ice packs that we had brought for the runners, like the ones you break and then shake. So not really ice, but some sort of chemical cooling pack that I would pad them with during the day when it was really hot to get them back in range, because it'll say like out of range on the actual screen. And so I would pad them with this ice thing. And then during when I was going around to the tents at night, when it was super cold, it also would be out of range. And so I would keep them like under my armpits, and I would walk around or whatever, and then like pull it out, try to do the cartridge thing while keeping one in my armpit. That would go out of range. And so I would pull out the next one that was warm from my armpits and inside my jacket. So it is super challenging. That was one of the really tricky parts of using an iStat in these environments. I have spent some time in the Antarctic and the Arctic, and we have iStats there, and no problems. Like in other environments, the worst place I've ever had to use an iStat is the Atacama Desert.
Well, thanks. Sorry if I dredged up some bad memories. Any other questions you had prepared, Janelle?
Yeah, let's see. So I did have a couple more. Did anyone listening in have any questions? Want to make sure I give kind of everyone a chance. Get any questions answered?
I just have a quick comment about it. Like what we have found is the sodium level does not correlate with symptoms. And so we're always in this really hard part. Should we check the sodium or not? And we don't always have iStats. Actually, they're very expensive and very hard to sort of manage, but sometimes we'll get them from Abbott to like donate for some research study. But we're always in this problem with their sodium is 128. Is that what's really causing their symptoms, or are they just feeling like shit because they just ran like 100 kilometers? We just don't know. And so our sort of philosophy is if we're going to check someone's labs, they're already out of the race. Like we're doing it for our own sort of like, what do we do? Because we just don't always know what to do with that number.
Thank you for that insight. I had another question, kind of with altered mental status and how hyperthermia and hyponatremia can kind of often overlap in presentation. Say it's kind of one of those situations that storing the iStat to get it to work is difficult. What are kind of some of your strategies in the field for quickly differentiating and treating those conditions?
I can take that. All roads lead to seizure, right? So, which is not good. The last thing, like Avi had said earlier, whenever he sees seizure on the medical form of an athlete, he gets a little bit nervous. Very reasonable. I also would get quite nervous. Hyperthermia. So if you're going to heat stroke, certainly there's a number of symptoms you can get to before seizure and coma and death, the final pathway of leading to death. But so does EAH. So does hyponatremia. It can also lead to seizure, coma, death. So if you are coming across somebody, or you're notified of somebody who is so ill that they're seizing, it can be a little bit tricky to differentiate between hyponatremia or heat stroke, but fortunately you don't really need to, because you need to do both things for them at the same time. If they're obviously incredibly hot, you need to find a cool environment or create a cool environment for them. And you don't need to pull out your iStat and try to measure their sodium. Just give them hypertonic. That is, you can treat both symptoms or both disease processes at the same time. And that would be what I would recommend if I came across somebody who in a hot, of course it would have to be, all of this is situational. You're imagining a hot environment, and somebody who you're concerned as well for hyponatremia. So that's how I would manage it. Obviously it can be a little bit tricky in these situations, but and certainly the one clinical difference, of course, is that the heat stroke person would be hyperthermic, right? So they're going to, by definition, they're going to have a temperature greater than 104 degrees Fahrenheit. So we don't, the problem, just like the sodium, is we don't really measure. I'm not going to stick a probe in their ass to be like, hey, like, what is their temperature? No, I'm going to treat them where they're at and do my best to kind of treat their symptoms and their seizure, not try to take their temperature in that moment in time, just like I wouldn't take their sodium. But it is tricky, and it is very scary to treat a patient like that.
Thank you for that insight. That was very, very helpful. Let's see, I have a question here from Kira, and the question is, do you find a greater incidence of hyponatremia in athletes who intake higher proportions of calories in liquid form, such as tailwind?
I don't know. I have not ever, I don't think we've ever made that distinction of looking at how they consume their calories. I don't know of any study that has looked at that. So I don't know. Maybe Dave, do you know?
I don't know. Just from my own, brief experience, it's the people who are using a lot of tailwind tend to be a bit more of elite athletes, to be honest, and they don't have problems. But that is obviously not sciencey at all. And if people are taking in most of their calories by liquids, I don't think it's related a lot. I mean, things like tailwind in particular obviously have a lot of sodium in them, but it depends on what they're taking, right? Whether it's liquid or not, it depends because you can take a lot of liquid in and do chicken bouillon, which is going to be very high in sodium, or you could do something very hypotonic. And so I think it relates less to the fluids and more to the sodium content to those fluids.
The other thing to remember is, like, the average person doesn't know that Gatorade is not sodium replacement. It's sugar water, but most people really believe that, even in this day and age, that these sports drinks are helping them replace electrolytes.
Thank you for sharing. And then Justin shared in the chat here kind of very interesting article that there was a case of a couple hiking in the Grand Canyon, and they purchased the Wilderness First Aid book. Didn't have a section on EAH and only heat illness. So they treated their symptoms with drinking a lot of water, worsening things. That's definitely interesting. It's sad that there was not a section on EAH in that book.
I was at the Grand Canyon in April, I think, this past year, and I will say that their information they give to park goers has significantly improved, which is good to see. I was there, I think, 8 years ago, and there was none of that. So their SAR teams are incredible, and they deal with this every day. So they've gotten much greater pamphlets available. It was on the map that you get at like the lodge. So
Wow.
hopefully things like this don't happen as often.
So I did a summer PSAR at Grand Canyon a few years ago, and before we started the trail every day, we bring down a backpack full of salty snacks, and we just hand them out like they're candy.
Yeah, the Grand Canyon probably sees more hyponatremia than like any other national park. Even on, I work on the Grand Canyon rafting. I guide river trips, and there was one case, I can't remember who wrote this up in our journal, but there was one case report of 3 people having seizures on one river trip within 24 hours.
Yeah, it's in the book, Death on the Grand Canyon. There was like a chapter on it where these women weren't eating, and they just kept on drinking, and they weren't peeing, and they sort of had this mysterious death, and it was only later that I think they identified it as hyponatremia. But it's in the book, Death on the Grand Canyon. And then there's another classic story, not exercise related, that was, I think it was like a fraternity in California where they made a kid like do calisthenics and keep on drinking water. It was like back around like 2005, and he died. And I sort of like water poisoning became sort of a national phenomenon back then. And I think California even made a law about hazing because of that incident of a kid dying, working out and drinking water.
Oh, that is so sad. It kind of shows the importance of kind of getting that information out to the public, and super appreciate everyone at the Grand Canyon, the STAR teams kind of spreading that knowledge. Let's see. Any other questions from those listening in?
I can just give you 3 quick cases in like 3 minutes if you want.
Oh, would love to hear them. Thank you.
Oops. That didn't work. Sorry.
While Avi's setting that up, Avi, take your time. The 2 things that so I mentioned there was one thing that I really took from that article, just to go back to that article for a second as Avi's sorting that out. But there are 2 other things that I really appreciated about that article as well when I read it. Having treated a lot of hyponatremia in my career in different facets, was I mentioned that the rhabdo cycle, how rhabdo can worsen EAH and vice versa. I thought that was really fascinating. It was really interesting to kind of get in a kind of in-depth understanding of that further. The other 2 things that I had were really the pathogenesis with ADP, and how that contributes. I know that that's the thing, and I know every time I know how it works, but reading it again for the 18th time is always really helpful. So in case you are like me, where you kind of get stuck at exactly what AVP or ADP is, ADH rather, ADH and AVP, the same thing, just different names. What they like, how exactly that molecule works on the kidneys. It's really nice just to reread that section just to kind of drill it into your brain, because if you're like me, I struggle with understanding that each time. And then lastly, for me, and Avi's actually alluded to this, that he wasn't so certain that salty things during the certainly electrolyte plans during the actual run would make much difference, because people have such a high sodium intake in their general food over the course of the day. The article actually, basically says that again. It basically says that it's a little controversial about the role of sodium supplementation during the actual race. I personally have trained in doing races really focused on the amount of sodium that I'm going to be taking in at each stage of the race. But I found it really interesting that it's not really proven in much data that taking sodium in during the race itself makes a huge difference. They do allude that it likely will delay hyponatremia, but again, probably won't fix it altogether. So I thought that was fascinating. I'm still going to be taking sodium or electrolyte drink when I do ultra endurance events, but it is interesting that the data is not really there. So those are my 3 take home points from that article, in case people were interested. Looks like Avi's up and running.
Can you see that? Sorry, it was taking a while. So this is one case. It was a 22-year-old male. It was day 5, and so he had already run 140 miles and came into camp just saying he's not feeling well. And we have a medical tent that we all sort of hang out in if people need anything. And he came to the tent and he was totally normal. He just kept saying he wasn't feeling well. He got a full neuro exam, and then we tried to kick him out. And at the end, he said, "How come I have my own tent?" Like, that was all he sort of said. That didn't make sense. And our runners share 8 or 10 people to a tent. And all of us sort of looked at each other and said, "What? Like, why does he think he has his own tent?" And so we talked to him a little more. He had minimal urine output. When we got to camp, he drank 7 liters of water because he hadn't peed all day. And then so we gave him a salt slurry. So we opened up some salt tabs and just mixed it in some water and made him drink it. And then this was in Egypt. So we started taking him to Cairo. He had a seizure in the car, and his sodium in the hospital was 109. And so this guy was talking to us with a sodium of 109 in the medical tent, and was just like slightly confused. He didn't remember anything that happened. He had a full recovery after getting hypertonic in the hospital in Cairo. Then there's another case, a 55-year-old male, day 3, had run 80 miles already, and he came into the med tent with cramping. He didn't feel well. We did like a full neuro exam, but he refused to leave the tent he just didn't feel well. And so we did not have any way to measure. All these cases were probably from like 12 years ago. He just wouldn't leave. And so he had a seizure in the med tent as we were trying to kick him out. And he had got rectal Valium. We didn't have any hypertonic back then. We had some Diastat, and we drove him 3 hours to Cairo, and his sodium was 108. He ended up getting intubated because he wouldn't stop seizing, and he got treated with fluid restriction and had a full recovery. This is a case, 31-year-old female, had run 80 kilometers on day 5. And then day 5 was an 80-kilometer day. And at 50 kilometers, just didn't feel well, had a headache, nausea, felt tired, which is every single runner, on our long day. She got some Zofran by the doctor and then was doing great or felt better, and then went to the next checkpoint. Still didn't feel well. Had an oral GCS, and this was one of our fellows, Dave Pomeranz, was with her here, and she rested for 3 hours, and then he heard a loud groan, and then she had a 90-second tonic-clonic seizure. And she, it turns out, in retrospect, had between kilometers 50 and 60, had drank 3 to 4 liters in 2.5 hours because she thought what she was feeling was dehydration. And so our fellow Dave put an IV in her, and her seizures actually stopped, but she didn't wake up. So he gave her 150 mLs of 3%, and she was still slowly waking up, but was still altered. So he gave her 100 ml aliquots over the next hour for a total of 500 mLs, and was still not totally back to normal. Had a 3-hour transport to the hospital, and her sodium was 121. So that was after 500 mLs of hypertonic. She got 3% in the hospital, and then was a GCS of 10 for about 24 hours until she finally recovered. And so that one was just a little scary for us because we thought maybe there'd been some sort of permanent neurologic issues. So those are just the 3 quick cases that I have. So these all 3 of these cases were sort of before, these are all old cases. We haven't had a case of EAH or seizures in quite a long time for a couple of reasons. One, we made our races much less extreme. The premise of our company initially was the hardest endurance events in the world. And so we made our races a little easier. We made our races now, for the most part, are vehicle accessible. Whereas we have had races in the past that people are totally on their own for hours until they're found either by another runner or a pack animal at the end. But mostly it's been education, just really educating these runners to not drink excessively and to come talk to one of us if they have any issues, to resolve their fear of that we're going to pull them from the race. So really, we're there to sort of help them succeed and not pull them out of the race. So people feel a little more comfortable, I think, coming and talking to us.
I had a non-exercise associated hyponatremia, non-medical case at the time because I was just a college student, but I had a roommate who was 6'9", and on a bet, I was not the one who gave him the money. Filled his entire tray with full glasses of water and chugged all of them throughout the lunch period. And it was like, I don't know, 12 to 15, 20 glasses. I can't remember. It's been a while, but he felt a little poor for the next 24 hours. And at the time, we didn't really know why. But in retrospect, that was a bit of a dangerous scenario we forced on this poor guy. But he won the bet, I suppose. So yeah, I guess it's like financial polydipsia led to a moderate hyponatremic event. What have you found is the most patient tolerated or participant tolerated salt content that you're giving them? Like, are you giving them just salt tabs? Are you giving bouillon cubes, ramen packets?
I mean, anything that they'll take, of course. I did Gobi this year, and we ended up sourcing some bullion because it's relatively easy to source there. And there was a really hard day where we were worried about people's, intake of fluids and, GI issues. And people were just taking these bullion like one after another. They just couldn't get enough of it. And I think people were tolerating that really well. Like really people were vomiting, had upset stomachs. Like they just were really bad before. And we gave them some bullion at a couple of different aid stations that day. And people were doing, they took that really easily. So I do find that people take bullion pretty easily, but honestly, whatever sounds good to them that has salt content is usually what works.
Yeah, I try to encourage runners to bring a variety of things for their own use, because maybe you're training on like noons that require large volumes of water, but so I think supplementation with multiple things while you're running. So salt tabs that you just swallow and you're sort of done with, in combination with like things that you mix in water. But I agree with Dave. I think when people are ill, I just want to get the highest concentration with the lowest amount of volume for their stomachs that are already sort of irritated. So salt tabs or bouillon. Or if they want some ramen, I'll make them, some ramen. But I think anything that tastes good or they can tolerate.
Can you tell our participants how they can get involved in stuff like this, or how to get more experience, or what you would recommend medical support people have experience in training in before being involved?
Yeah, there's definitely lots of ways to get involved in any, I think like kind of these ultra runs are just right up our wheelhouse as wilderness medicine doctors, sort of combines emergency medicine, sports medicine, wilderness medicine. And I found that really emergency medicine doctors are sort of the most well prepared for our races. But there's definitely lots of front country races you can get involved in, like your local marathon, has aid stations. There's tons of ultras locally that you can get involved with. I know the Western States, which is sort of one of the most famous races in the world, takes a ton of volunteers. Our races, you can definitely go online and apply to be on the medical team. It's more how we sort of keep track of people through our online portal. We don't typically take residents to be on the medical staff, but we take residents. We always have an ongoing research project. So we do take residents to help with like a research project or fellows. And then you're also part of the medical team, but that's not your primary role. And the reason we do that is because, if something goes down, we need someone who can be sort of fully independent. So it's because if you're evacuating a runner, I don't want the first call to be to me. I want the first call to be to one of our management team who can organize you logistics on how to evacuate somebody. And so we definitely prefer sort of on our main medical staff, someone who is done with training and has some experience, because we are in like a very foreign place and you might be on like a 5-hour ride to get to a hospital, and you'd be very comfortable taking care of somebody in a car. So yeah, Dave, you want to add anything to that?
Just that, before I went to medical school, I got a degree in exercise physiology, and myself was a very amateur athlete. and I just love this stuff so much. And I cold called a lot of different people and found myself in the Atacama Desert, but with Avi, but also had just cold called a lot of different places and, different endurance events, or, I volunteered for the Boston Marathon a number of times. Like just found myself in all these different situations, and you never really know which ones end up giving you a lot of experience. I did a 24-hour Tough Mudder event where, people were suffering from hypothermia very dramatically and with like wild amounts of people. And it was certainly an MCI event that as a second year resident I was helping to manage. And you just never know when you get some really great experience from some of these races. There, like Avi said, there's so many local events that are really easy and really need your help. to keep people safe in some of these events. Sometimes you go to like events of some mountain biking ones there, I'm like, oh, this has the potential of having a lot of trauma or something. And literally didn't do anything a whole day other than try to fix somebody's spoke, and you're like, all right, well, that's good for them, and so of course that's great stuff. So I think you just throw your name in there when you have some time and you have some energy to kind of research some races and research if they need some volunteers. But I think I've amassed enough experience to make me feel pretty competent and really in any kind of endurance race, wilderness medicine type of event. And but it does take a lot of experience, and so just put your name out there.
Does anybody have any cases they want to talk about or questions about EAH or race medicine? All right. Well, I think we're at the 1.5 hour mark. Anybody, Dave, Avi, any parting wisdom? Andy, if he's still here, I think he left.
I would say it's super fun. Try to get involved in stuff like this if you love. I mean, I love it. It's really fun. Very rarely do you get to spend like a week in a desert with some of your closest friends as an adult, so it's super fun, very rewarding. We help, we have blind runners and diabetics and all kinds of people that we really work hard to sort of get to the finish line. So that was one other thing that was my presentation that we didn't get to, is what we found in our insulin dependent diabetics is that when they're exerting themselves, they use like the minimal amount of insulin. I mean, just like hardly any during these events. So whatever cortisol response they're having. But yeah, no, thanks for joining us and listening to us, and thanks for your questions.
Yeah, thanks, Dave and Avi, for joining. And I think Alexander has left us for the evening, and Janelle for helping pose the questions and running the moderation of the discussion. The schedule for the spring 24 series is coming out shortly, hopefully. Just nailing down dates. Topics are going to be like wildland fire, altitude medicine, avalanche rescue, emergent pulmonary edema, and let's see, base and station medicine. So we're going to kind of combine some more of the niche topics with some of the bread and butter. So it should be a fun next series as well. And next month is going to be climbing injuries, and Chris Davis of Wake Forest is going to be joining us with that. I'm going to end recording. I will see you next month on climbing medicine.